recognized for my musical talent as well as the scientific side. And actually, our band, The Void, is playing a gig at the AUA in Chicago in a couple of weeks at a place called the Jazz Showcase, which is this storied jazz club that every great jazz pianist from Miles Davis and Cannonball Adderley, et cetera, have played at. So we've got a high bar to reach in a couple of weeks. It's focused our attention. But yeah, so I wanted to present today, and actually it's glad to see there's a good turnout. I wasn't sure how many people would come on Easter Monday. It's a very multidisciplinary group. That this field of how we diagnose and to some degree stage prostate cancer has really evolved rapidly. New tools and new concepts, partly related to genomics, partly to imaging, partly to clinical experience. A lot has changed, and I thought it'd be interesting to review this. So I've had research support from Exact Imaging, who make the Exact View micro ultrasound device that was developed at Sunnybrook by Stuart Foster's group, and I will discuss that briefly. So just, it's a general audience. This is kind of the basics. 24,600 men diagnosed in 2023 is the estimate. 20% of new cancer cases in men. It has a big footprint in the oncology world. 4,600 deaths, so roughly one in five who are diagnosed will die. 10% of cancer deaths, 67 diagnosed every day, 13 deaths per day. And a major public health achievement, which has not been seen in most cancers, is over the last 25 years, a 40% reduction in mortality in prostate cancer. And there's a lot of debate as to why this is, but I think most agree that it is at least to a significant degree, probably at least 50% of the reduction, if not more, is due to efforts at early detection and screening. And while the whole issue of screening, which is another topic, still remains controversial, the Canadian Task Force on the Public Health Exam, which by design is a non-expert panel, continues to have a negative assessment of screening, which is, I would say, widely ignored by practitioners. PSA testing is widespread, and the basic concept of PSA testing done in a more sophisticated way than was done 15 years ago is warranted and has value. So that, again, is a whole other topic, but just about everyone who is in the field believes that it has value, and that if it's done intelligently, that and that includes things like avoiding overtreatment by incorporating active surveillance into the management protocol for favorable risk patients, that it has a lot of value for men. And this is just to show, I know you can't see this, but this is better. This is the mortality reduction per year over the last 20 years or so around the world. And what I just show this to show that not every country has seen a mortality reduction. Canada has had a greater reduction than most countries. You can compare it to the United States. And this is, again, correlates pretty closely with efforts at early detection and use of PSA by country. So now I'm going to move really to what we do in the patient who is at risk. So the conventional paradigm is PSA, if it's elevated or if the patient is determined to be at risk. Nowadays, most practitioners use some kind of risk nomogram, either online or in their head, to incorporate other risk factors like family history, race, age, and so on, to decide who is at risk and who is not. This can be done very effectively with widely available computer nomograms. And then to move to systematic biopsy, this has become very common, 1 million per year in the US. It's about 1/10 that in Canada. And this has been done conventionally with ultrasound, standard ultrasound, which is good for visualizing the prostate. You can see a typical image there, but it does not have sufficient resolution to visualize all but the largest, highest grade cancers, which occasionally you see, but it's not sensitive and it is not specific. It guides the biopsy needle. So there's been a recent shift over approximately the last decade to MRI imaging prior to biopsy. And this was not funded in Canada until about 2 years ago. And since then, it's now considered an insured service. It's become much more widely available. But once you have the MRI, the patient then still has to go on to a ultrasound to guide the needle. And the question when you do the biopsy, nowadays the patient has an MRI, there's a target. If there's no target, do they still need a systematic biopsy? Depends on the risk. If they're having a targeted biopsy, do they still need systematic biopsies as well? So this has real implications for patients, which I'll come back to. So to cut to the chase, and this is where I'm going with this presentation, if we move to an image-guided strategy, and what that means is that you basically target the image seen on MRI or high-resolution micro-ultrasound, and you disregard the normal areas of the prostate, which is not what has been done historically. And I'm going to go through why I think this is a good idea. First of all, no need for systematic biopsies in men having targeted biopsies. A typical targeted biopsy is 3 cores. A typical systematic biopsy is 12 to 14 cores. If it's done transrectally, it makes a difference in terms of the risk of sepsis, the additional cores. If it's done transperineally, it's more discomfort for the patient and greater risk of bleeding. It can avoid the addition of avoiding having to do 12 or 14 biopsies means quicker procedure time, which is nice for both parties, lower burden on the pathologist, fewer side effects. In the men who have negative imaging, if this concept is accepted and validated, it means you can avoid biopsy in somewhere around 40 to 50% of men whose imaging is negative. It means we're going to find less grade group 1 prostate cancer. No one thinks that finding this is a good thing for men. It leads to the whole psychological impact of a cancer diagnosis and so on, even if it's managed conservatively. Fewer need for biopsies in men who are on active surveillance for low-risk disease. More confidence in focal therapy. Again, another topic, but the criticism of partial gland ablation is most prostate cancers are multifocal. You're leaving part of it untreated. But if the idea that the invisible cancers are not clinically significant is validated, then this supports the idea of focal therapy. And finally, the men who don't have a biopsy, who have elevated PSA, who may wonder, have I really got something, and am I making a mistake? So it would reassure these patients. So some of the background, we did this study called the PRECISE study, which had the primary publication about 2 years ago, which was a national randomized study comparing MRI with only targeted biopsy, which is really the diagnostic strategy I'm talking about, to systematic biopsy in all patients. This was OICR and CCS funded, 1-to-1 randomization. So in the MRI arm, which was really considered the experimental arm, if the patients had a target, they would have a biopsy of that target. If it was negative, they wouldn't get anything. The other group got the 12 cores in all patients. And the most, we built into the study a 2-year follow-up with MRI in both groups. And the question was, in the men having an MRI that was negative, who didn't get biopsied, were we missing significant cancer in many of these patients? And how did the 2 groups compare? So, and there were a number of secondary outcomes in addition to the likelihood of finding significant cancer in both groups. And the primary publication, as I said, was about 2 years ago. It was a very positive study in the sense that it demonstrated non-inferiority of MRI with only targeted biopsies. About 40% of patients in the MRI arm had no biopsy, but despite this, there was 5% more significant cancer found in the targeted biopsy arm than the systematic arm. There was less than half the grade group 1 cancer found, fewer adverse events. And, you know, as a trialist, you always wonder, what's the impact of my trial? And this trial really had an impact in the sense that about 2 weeks after this publication, Cancer Care Ontario modified its guideline to an imaging prior to biopsy recommendation. And this was a major effort, this study, that involved a lot of people from Sunnybrook, Andrew Loblaw, Masoom Haider, some people from ISIS, PMH, and 3 other centers across the country. So this was really a gratifying initiative, but it left open the question that I referred to in the biopsy negative patients, you know, is how safe is this? It looks as safe as systematic, but is that a problem? And there's also the issue of cost. You're proposing to do MRIs in a large number of patients who weren't getting it before. So to address these 2 questions, first of all, we did this 2-year follow-up. So this is actually brand new data. This is just about the first time this has been presented. It's going to be presented at the AUA in a couple of weeks. We did MRI in all the patients in both arms. And to make a long story short, just before we get to that, let me just show that COVID had an impact on the follow-up. Unfortunately, about half, almost half of the patients didn't show up for their 2-year MRI. They were afraid of coming to the hospital. And although we struggled mightily to get them in, we were only partially successful. So that does limit the strength of this. But basically, we didn't find any difference in upgrading at 2 years in doing MRI in all of these patients 2 years after the initial biopsy. 4 patients with grade group 2 in the MRI group in the 2-year interval, none with higher grade cancer, and 6 in the systematic biopsy. And then we also did this economic analysis in conjunction with Nicole Mittman at ISIS and some of the other ISIS folks, using de-identified health insurance claims for all the Ontario patients, which was about 60% of the patients in the study. And to make a long story short, because more cores and more patients having biopsies in the systematic biopsy arm meant more hospital visits, more complications, more sepsis, the cost of that basically was equal to the cost of the MRIs in the MRI group. So here is the cost. There's essentially a trivial, non-significant difference in cost between the trust biopsy arm and the MRI arm. These were mainly transrectal biopsies. If you do transperineal, there's less sepsis, but still, what this shows is that compared to the conventional approach, it's cost effective to do MRIs in these patients despite the additional cost to the MRI. So we're not the only ones that have looked at this, and I know you can't see this details, but this is a recent systematic review of this topic. This came out just before our paper was published, so it's not included, but just to show, let me just see here. Yeah, this is the putting all this data together of various prospective trials, mostly not randomized, but the MRI targeted biopsy looks better than the conventional approach for the detection of significant prostate cancer. Now, if you look at these trials, this is another systematic review, it's clear that targeted only biopsy misses a significant proportion of patients. So the light bar here is systematic, the darker bar is targeted, and the darkest bar is the combination. And every single trial shows somewhere around 15% of patients who have only targeted, or to put it another way, who have targeted plus systematic, the systematic finds significant cancer at about 15%. And people worry about this a lot. Just to emphasize another point about the limitations of MRI and targeted biopsy, this was an earlier study, also randomized, that we did in men on active surveillance, randomizing them between MRI plus systematic biopsy to systematic biopsy alone. This study was designed to be positive. You would think you add targeted biopsies to systematic, you're going to find more cancer, except we didn't. And this shows that even in the patients with the worst MRIs, this is PIRADS 5, only a third of the patients had significant cancer, compared to more than 80% in an earlier landmark study in New England Journal called the Precision Study. So you could say, you know, we had a problem. The problem was the learning curve. We bought 3 fusion targeted devices for the 3 centers in this study. And in retrospect, they didn't have the expertise to do fusion targeted biopsies accurately. It's the only explanation we have for this. And I think it's also an issue of generalizability, that MRI with fusion targeting may not be as accurate in many people's hands as in the reports from the Centers of Excellence. So you've got this issue of the missed significant cancers, which tends to drive a lot of anxiety, which drives systematic biopsies, which drives radical treatment when maybe focal therapy might be good enough. And so there's this hypothesis that image negative cancers are mostly indolent and that therefore you don't have to worry about them. And that is the case I'm going to make. So first of all, there's the genomics. And actually, I'm sorry that this doesn't show up better, but this is one of several studies that compares gene expression in patients with visible cancers on MRI to invisible. And it is dramatic how MR visibility disaggregates these cancers according to gene expression. And you can see that a number of the genes involved, critically important genes involved in cell cycle regulation, in invasion, in metastasis, are altered in visible cancers and not altered, or not altered as much in invisible ones.
About his appointment.
Someone's got to mute their mic, please. And the conclusion is, which you can't see too well, genes involved in cancer progression are associated with cancer visibility on MRI. So one very powerful genomic study, and there's several, and they all show the same thing, that visibility is associated with worse genomics. Here's another one from UCLA, this concept of nimbosis, which means it's from meteorology, gathering of stormy clouds. The stormy clouds are the combination of genomic instability, hypoxia, SHLAP1 expression, which is a gene that's involved in associated with clinical aggressivity. So this idea of nimbosis, that this confluence of aggressive molecular features underlie MR visibility of localized prostate cancer, is gaining credence. So here's the UCLA study, and you see SHLAP, hypoxia, and image, and essentially these are closely correlated. And you can see here that the positive predictive value, or maybe a better way to put it, is the correlation between PIRADS and these genomic characteristics called nimbosis is quite strong. And then you have some clinical data that I would say is equally compelling. So this is one recent study from Memorial Sloan Kettering, about 1,500 men having a radical prostatectomy, stratified by visible versus invisible cancers. And, you know, when was the last time you saw Kaplan-Meier curves that had as much space as there is here between the red line, which is visible, and the green line, which is invisible? And this is biochemical recurrence, metastatic disease, prostate cancer specific mortality. Essentially, the invisible cancers look like non-lethal cancers. Now, of course, the confounder here is they were all treated with surgery, but still, this is a strong clinical support for the idea that these cancers tend to be considerably more indolent. And then finally, one more study, again, visible versus invisible, not quite as dramatic as the previous one, but still quite substantial difference between visible and invisible. This is also stratified by Gleason. The other side of the coin, that phone will stop ringing in just a second. The other side of the coin is what are the implications of having strongly visible cancer? And this is one very provocative study that came out just a few months ago from Germany of men who were diagnosed only based on image. They had positive MRI, positive PSMA PET scans. So these patients had no biopsy and they went on to have a radical prostatectomy. This is heresy in prostate cancer circles to be treated radically without a biopsy. They all turned out 25 out of 25 had what would be considered clinically significant cancer. So this is just an initial pilot study, but this really reverberated because this implies that you may be able to make a diagnosis of significant disease just based on imaging. And again, reinforces the idea that MRI visible cancers tend to be more aggressive. You throw in PSMA and it looks like you have almost complete specificity for a significant cancer. I mentioned high resolution micro ultrasound earlier. This is a massive Sunnybrook success story. My experience with this was that about 15 years ago, I was doing research in S-Wing we were studying orthotopic murine prostate cancer. These are very, very tiny cancers. And I heard that Stu Foster's group had developed a microscope ultrasound that you could image 500 micron, that's 0.5 millimeter cancers in a mouse prostate without sacrificing the animal. So that was very exciting to me, and we did several studies with this. I never thought that imaging a 0.5 millimeter cancer in a human would have any value, but it turned out to have huge value because the resolution of this micro ultrasound, which is 29 megahertz compared to 6 to 9 with conventional, allows you to image alterations in a prostatic duct. And that, of course, is a key feature of higher grade prostate cancer, that you lose ductal anatomy. And it looks and costs similar to a fairly high-end ultrasound, not more. And again, I'm bringing coals to Newcastle. Probably most people at Sunnybrook, at least I hope, have heard about this, because this is now being adopted with enthusiasm all over the world as an alternative to MRI. And this shows you the difference. These are both with the same device, but this on the left is the lower resolution, on the right the higher resolution. This speckled pattern is what normal prostate looks like. Each little white dot is a duct, and as the cancer increases in grade, you lose this ductal anatomy. It can be done with transrectal or transperineal biopsy strategy. This just shows, this is what I use, is this stepper guide that allows you to really be quite accurate in terms of where you put the needle. You can also use a brachytherapy template, and you see these patterns that are really not normally seen with conventional ultrasound. This is called bright echoes, that's associated with higher grade cancer. You see needle tracks, you see anatomy very clearly, neurovascular bundle. Again, these are things that you only see dimly or not at all. This grading system has been developed. I'm going very rapidly through this stuff. This shows needle tracks 5 years after the initial biopsy, so you can put your needle in precisely the same place it was previously if you want to re-biopsy an area. And this just shows, so you can imagine with MRI and fusion targeting, the way that works, you have the MRI, the MR radiologist, you hope he's expert. They are at Sunnybrook, but they aren't in a lot of places, accurately defines the lesion. And then you use a fusion targeting device, either your brain or a relatively expensive fusion targeting system like Artemis or Euronav that superimposes the MRI image on the ultrasound. And if everything works out, then you accurately target. It didn't work out for us in the ASSIST study that I showed earlier. Whereas here, there's the lesion, and you line it up, and boom. You can be essentially 100% sure that you've actually targeted that lesion. That was transrectal. This is transperineal. The needle is now coming in sterilely. The reason we prefer this, I'll come back to that, is because the issue of sepsis was a persistent problem with transrectal. 3 to 4% of patients would get significant sepsis after a transrectal biopsy. People call it a transfecal biopsy. And this practice is now changing, has changed at Sunnybrook. So again, there you see lining it up. It was visible on MRI, but you don't need the fusion software. It's also one stop. The patient comes in, has the imaging with ultrasound, and is biopsied. So this to me is a huge advance. There is an anterior lesion seen on ultrasound, that dark area. And so again, you come in a little more anteriorly, transperineally, and really with high confidence that you're accurately targeting it. And this was a relatively early study that I published a couple of years ago, the first 11 sites in the world that started using this. I was lucky because of my earlier association with the Foster Group. I got one of these shortly after it became available. And really, I haven't looked back. So this is a summary comparing MRI to ultrasound in the first 11 sites around the world. It reflects the learning curve. It was a registry, not a prospective trial, so it's flawed. But what it showed is the sensitivity of ultrasound was at least as good as MRI, actually slightly better in this study, and the specificity was comparable. And now there's better data. This was a formal blinded study from Milan that essentially showed at about 60% of cases, both modalities saw the cancer. In a quarter, it was only seen on ultrasound, and in about 15% only seen on MRI. One thing that we have no idea about is what the histologic and or molecular characteristics of cancer are that make it visible with one of these modalities and invisible on the other. So that's an area for future evaluation. So this has had a major effect on my practice already. The whole feature of one-stop shopping, the patient comes in, is imaged, and biopsy is very appealing. It's expensive. You can imagine in most of the world, getting an MRI in everyone who's got an elevated PSA is simply not feasible. You could probably include Canada in that list of countries, but places like Southeast Asia, South America, they think this technology is just fantastic. And it's already had a significant impact in my practice in that if the ultrasound is negative, then I avoid the biopsy. I alternate it with MRI and men on surveillance and so on. I mentioned this shift to transperineal biopsy. I just want to focus on this for a couple of minutes because it's been a major change in terms of how we do things. It's made the biopsy much more appealing. So transrectal was how it was done for 40 years. The rectum is close to the prostate, so the main advantage is the needle doesn't have to travel very far in tissue, maybe a centimeter from the rectum to the edge of the prostate. Analgesia is straightforward. Transperineal is sterile, and that's the big advantage, and no bleeding, no rectal bleeding as well. There are more challenges with anesthesia. But the big problem with transrectal biopsy was, as I mentioned, somewhere around 3 or 4% of men got urosepsis, others got bleeding, and also men universally did not like transrectal biopsies. And there was a definite rate of refusal, particularly once they'd had it once. So transperineal is kind of emerged. This just shows that the accuracy of transperineal is comparable based on all these studies comparing diagnosis rate between the two approaches. This is another one, same idea, randomized trials. I showed this slide already just to say that you can do transperineal with a template, which is how the radiation oncologists do it, or you can do it freehand with this this so-called transperineal guide, the way I do it. I don't think there's some pros and cons of both. And this is just to show that rectal bleeding, dramatically less common, fever, dramatically less common, hazard ratios here of 0.02, hazard ratio 0.26. So fewer complications. But here's what to me is, this kind of spoke to me, this story. This is Norwegian newspaper. And this is a story about a man named Roar Gulbrandsen, age 68, who had a transrectal biopsy, perfectly healthy guy, had a transrectal biopsy, developed sepsis and died. And we know this happens, the rate is somewhere around 1 in 10,000 to 1 in 2,000. But every time it's a catastrophe. And he had these very photogenic looking wife and daughter who learned about this whole issue and created a public relations campaign in Norway to end trust biopsies, transrectal biopsies. And this caught on. The public became enraged. The prostate cancer community in Norway did not look good. And they initially pushed back, but they were overwhelmed by public sentiment, and almost overnight, within a year, transrectal biopsies in Norway stopped, and there was widespread adoption of transperineal biopsy. So I thought, when I first saw this, I thought, we don't want this kind of public relations campaign in Canada or United States. Still, the majority of biopsies are being done transrectally, but it is changing as we speak, and I think it's a very positive trend. So just some further thoughts as I conclude. As we move to rely on imaging, whether it's MRI or transrectal or high resolution micro ultrasound in the diagnosis, we're increasingly finding this group of patients who have only a solitary visible lesion and intermediate risk disease. And the appeal in these patients is to do the equivalent of lumpectomy for breast cancer, partial gland ablation for prostate cancer. We can do that with a variety of ways. Tulsa, the other major Sunnybrook innovation from the imaging research group at our place, HIFU, cryo, brachytherapy implant can be done in part of the gland, a new technique called IRE or electroporation. So there's a lot of ways of doing this. It's all about selecting patients properly, but this is very appealing to patients because it does not have the same quality of life effects as radical therapy. And I think this is going to be the future for probably a third of patients going forward. And if you look at the number of patients involved in this whole story, between the shift to transperineal, the shift to image-based diagnosis, the shift to partial gland ablation with preserving quality of life, it all adds up in a very considerable way. There's a lot of unmet needs, and there's a lot of research opportunities in this whole area. The concept that I've proposed today is not widely accepted, I would say. It's really at the beginning. It feels a bit to me like active surveillance did about 20 years ago, which is, it makes a lot of sense. There's very good preclinical and clinical data supporting it, but very few people actually accept the principle. So it needs to be validated. We need more studies of clinical outcome, of safety, genomic studies confirming the studies that are out there. We need to interrogate existing databases, including our Assure database is now up around 1,600 patients. We have MRIs on virtually all of the men who have entered the database over the last decade or so. And so there's a lot of interest in interrogating our database and others for this data on the natural history of visible versus invisible cancers. We don't know what it means. As I mentioned, micro ultrasound invisible, is that have the same favorable implications? And what about PSMA, the new molecular targeting radionucleotide study? I think most people think that PSMA invisible is very favorable, but we don't have much data on natural history. There's the intermediate, the gray zone, PIRADS 3. Based on a whole lot of data, PIRADS 3 out of 5, which is the MRI grading system, doesn't really move the needle in terms of risk. We don't know if these patients should be treated as if their cancer is visible or invisible. So there's the gray zone to sort out. And then on the other side of the coin, what about grade group 1? We manage those patients with active surveillance almost universally at Sunnybrook. But if they have a PIRADS 5 lesion, you rebiopsy it, it's still grade group 1. Is this a marker for adverse disease biology, or maybe they still have a missed cancer? So again, that's a question we don't really have a handle on. So to conclude, the paradigm has changed in a very positive way. I think imaging before biopsy is now the standard of care. MRI has a lot of limitations. High resolution micro ultrasound, very appealing alternative. They're complementary. They make a lot of sense to be used together, but by incorporating ultrasound, you can do fewer MRIs, less gadolinium, less inconvenience for the patient, less cost. The shift to transperineal biopsy, which most people at Sunnybrook doing biopsies have now done, at least I have, and I know the radiation oncologists have. The radiologists who do biopsies, I think, are still doing transrectal, and I believe so is my colleague, Dr. Nam. So this is still an evolution, but I think it's over for transrectal biopsy, in my opinion. And finally, that there's increasing evidence that these invisible lesions are mostly indolent, and this really strengthens the appeal of this partial gland ablation strategy that we at Sunnybrook have a lot of interest in, and I think will make prostate cancer treatment much more appealing to patients going forward. Thank you very much, and looks like we have a few minutes for questions.
Hey, Laurie, thanks so much. I'm at the age where I have to think about prostate cancer screening myself.